I'm glad this course is happening because this makes us, you all, leaders in a global movement which is yet in its infancy in low and middle income countries. I'll explain what I mean by that. But first, while I get my slides on, please think. You are oncologists, but primarily we'll never forget that you are healthcare providers. Your generic name is doctor, and a doctor is a healthcare provider. As a doctor and as a healthcare provider, if somebody asks you, how do you define your duty to the patient? Duty of care to the patient and family. Sorry. In many countries, that's defined by law. In the UK, for example, the law is there defining the duty of care of a doctor, not in our country. But the next best thing that can happen is what we have is a statement by the statutory body of Government of India. That is the bioethics unit of the Indian Council of Medical Research, who define your duty and mine thus. Did you see the last sentence? There exists no exception to this rule. I am almost 77 years old. I know that I have at least 10% chance of dying with cancer. Any one of you could be my doctor. And doctor, this is my request to you as a patient. Please accept your responsibility to mitigate my suffering. I hope you will be able to see me, not only the cancer in me, see me as a person. Remember, let me remind you, that is not a favor that you will be doing to me, that's your duty. And as a future patient, I am claiming that right. And you have all signed up for this course precisely for this purpose, to relieve suffering. Thank you very much for being here. This site, some of you have already seen this image, happened many years back. This man had been in this position for most of 6 weeks. He had been in severe pain for 3 months, the second half of which he had lung cancer, which had spread to his bones. Eventually, this was the only position that he could tolerate. The family said he would roll to a side and take a nap for a few minutes, then he would be back in this. But the family said something else. The person who is crouching there is not the grandpa we used to know. He was a caring, loving person. And he was the person who gave us the most love in our family. He's not there any longer. This is one of the tragedies of health-related suffering, that it changes people. Some of you may be stoics. Some of you may be crybabies like me, who cry out in pain as soon as a needle goes in. But some of you may be stoics. First, I hope you will accept that I have a right to be the crybaby I am. That's the way I'm made. Please don't expect me to be as strong as you. But even you, the strongest person who can tolerate a lot of pain, must realize that there can be pains that cannot be tolerated by anybody. Pain can be so agonizing that it can occupy every square millimeter of your mind space. I have had one person tell me that he had an osteosarcoma, and he told me that what he felt was like somebody putting a red hot iron into his uh, leg and twisting it all the time. Another person with a cancer of the tongue told me that what he felt was as if somebody was putting a nail to his ear and driving it with a hammer. And please remember this. He had stopped talking to his loving uncle, who came and told him, sorry, a sentence in Malayalam, കുറച്ചൊക്കെ സഹിക്കണ്ടേ മോനെ, നീ ഒരാണല്ലേ. And he never forgave that uncle till the moment of his death. So when we enjoy the arrogance of health, we think we can tolerate many things which we may not be able to. This same man was resurrected as the loving uncle in less than 1 hour. By the time about 6 rupees worth of intravenous morphine had gone into his veins, if I remember correctly, he had 12 milligrams, 1.5 milligram given every 10 minutes, sat up and enjoyed his first cup of tea in 6 weeks. It may not always be as dramatic as all that. I took the most dramatic change around. Very often it's not dramatic like that, but the difference can be remarkable, not only in relieving his suffering, but bringing the person back to the person he was and giving their loving grandfather or loving spouse to the family. So that emphasizes my earlier question, which I will repeat now. You have a duty not only to treat my cancer. Thank you, doctor. Thank you for treating my cancer, but you have a duty to relieve my suffering also. And unfortunately, we live in I don't know if you know this, India is among the worst 12 countries in the world. This is World Bank data. You can just Google for World Bank and go into this. Google for catastrophic health expenditure. India is among the worst 12 countries for catastrophic health expenditure, where more than 4% of the population get destroyed going below poverty line by catastrophic health expenditure in 1 year. This is not cancer. This includes cancer. This is any health-related service and any healthcare cost. 38% of them are due to the cost of medicines. 38%, 38%. 38 million of the 55 million are due to the cost of medicines. The prescription that I write has the power to starve the child and the family for a night. This is part of the suffering. Is it my responsibility as a doctor to look after this also? I would accept that responsibility, because what is worse than not treating the pain is to inflict suffering. What can I do? Well, I can't change the world all at one time, but I can take another look at the prescription. I am likely to write the most familiar brands, which is what the medical representative comes and tells us. I have a question to all of you. Manu, please note the chat box for me. Has anybody, any medical representative, come and talk to you about immediate release oral morphine? People may have taught you about fentanyl patch and about sustained release of morphine, immediate release morphine. Maybe they have, but I guess not. My guess is that they haven't. No medical representatives comes and tells you about the cheap medicines. And the current regulation of writing only generic medicines doesn't solve the problem, because the pharmacy would still sell only the expensive brands. This photograph is someone that I personally took. This kind of scar, we used to see 3 or 4 times every year, but it is much less now, not because incidents of suicides are less, because less people hang themselves now. More people tend to take poisons. The pattern has changed, that's all. The numbers are huge. But I'm just addressing the people that I see before us. Doctors are Irfan, Devashish, and Saumen Das, Dr. Manjusha, Dr. Geeti. Just make a guess. For every person who successfully kills himself, how many people would be trying and failing? It's very fashionable to cut one's wrist nowadays. You see horizontal scars. They don't know the anatomy. And because the pain, they don't go deep enough. People try to kill themselves by cutting the wrist. Or poisons. For every person who succeeds, I guess there must be 15 people who try and fail, or more. And for every person who tries and fails, there must be dozens of people wishing they had either the physical or emotional strength to do it. Of course, this is not only cancer, it's all diseases combined. Uh, my practice of palliative care started at a time when this WHO ladder had not yet entered the books. It came up in 1986, but it entered, I remember that it came into Davidson textbook of palliative, there's the textbook of medicine only by the end of the 90s. So most textbooks, and pharmacology textbooks, it took much longer. One of the sessions that you will undergo will be about accessing step 3 opioids. The first step is just non-opioids, which includes paracetamol and other NSAIDs. In second step, you add a weak opioid. Most the inexpensive ones have been pushed out of the market, like restopopoxyphene, unfairly, I believe. That's common. Inexpensive medicines get pushed out by creating evidence against them. And only an expensive one called tramadol is available now, practical for all practical purposes. And if that's not enough, you continue the step 1 medicines, take away the weak opioid and substitute a strong opioid. The only opioids of that class that are available for oral consumption would be morphine. And anybody? Put it upon the chat box, please, unless you are, or you just unmute and speak. Sangeet, Manu, please monitor the chat box for me.
Sure, sir. Sure, sir.
Sure, sir.
Before you complete the course, I'm sure you will learn about this medicine. I'm talking about methadone. Again, too inexpensive. No medical representative has come to you with methadone, most likely, because it's inexpensive. It's as inexpensive as immediately is oral morphine. But it requires greater learning and more learning and greater expertise to use it compared to morphine. But for a lot of people who do not tolerate morphine, this solves the problem. I remember Dr. Aju Matthew once tweeting that is the first time he came across methadone and how it transformed a patient's life who was not tolerating morphine. But apart from these two oral medicines, there is one other medicine that's not available orally. That is not oral and not parenteral. You know what that is, what the medicine I mean. Would you like to put it upon the chat box? The only other step 3 opioid in India,
So Dr. Irfan says it's fentanyl.
fentanyl, yes. So, I mean, some newer congeners of fentanyl keep coming into the market and going away again. But we are talking about transdermal fentanyl. Fentanyl is not effective orally. So, fentanyl can be used transdermally. Very convenient. Just stick up a patch. Don't worry about swallowing all those tablets. And has some advantages over morphine. But who wants to take a guess about what are the major disadvantages? Why would not I put in as a first line medicine? For me, it's a third line medicine. For me, if step 3 opioid, oral opioid, step 3 opioid, not parenteral is necessary. First is or immediately is oral morphine. Second would be methadone. And then only fentanyl would come in.
Dr. Mohammed Shafi says dose titration.
Yes. Thank you, Dr. Shafi. For initial titration of opioid, as Dr. Shafi says, it is not very useful. See, if in my times, if I come to you, for most medicines, you will know the dose. There's a standard dose for adults, or you may calculate by body weight. You can't do that with step 3 opioids. For morphine, methadone, or fentanyl, the dose required is whatever is minimally required to treat the pain. So I have paid, most of my patients would be on somewhere between 10 to 15 milligram or 20 milligram at the most 4-hourly, majority. But I've had a lawyer who used to take 150 milligrams and would still practice law for 2 years. Sometimes there are people like that who require high doses. And when you give somebody more than the person requires, so if a patient requires only 5 milligrams orally morphine and you start with 10 milligrams, you know what will happen? All that will be dealt with in detail later. The patient may get delirious, too drowsy even to eat, and may get myoclonic jerks. I'm not talking about toxic symptoms, toxic manifestations like respiratory depression. I'm talking about clinical dose and side effects. So you have to use the lowest possible dose to treat the pain adequately, at the same time avoid side effects. And with morphine, you will know. You give a dose and you will know within 1 hour. And then you can, for 2 days, it takes to build blood level. Every alternate day, you can increase the dose or decrease the dose. With fentanyl, you cannot. It will take at least 24 hours to see the optimal result. And by that time, the patient may either not have enough pain relief or may get drowsy. That's why Dr. Shafi said it's not good for initial titration. Dr. Shafi, I don't know if anybody else has mentioned the disadvantage.
Dr. Manjusha said it's cost and availability.
Thank you, Dr. Manjusha. Availability is better. Oh my God. You just ring up the company and the medical representative will be there the next day. And if you want the official license to get it, you just have to fill up the form, or even he will even fill up the form for you. Not for morphine, but for fentanyl, because it's about 150 times the cost of immediate release morphine. 150 times. And we have a few questions to ask ourselves if we are justified in using it as a first line medicine. At the same time, I recognize its value as a third line medicine. For somebody who can afford it, you have titrated with morphine, then switch over to the appropriate transdermal fentanyl, and the person can go to work comfortably without having to swallow tablets in between. But I am not going to the details of pain relief. I just wanted to point out some things that I hope, will carry home with you at the end of the course, so that, so that, Dr. Prajesh, so that I'll feel much more safer coming to you for treatment. But I also must mention some problem with end-of-life care. This is again something that we dealt with in detail. Hey, who is going to read this out for me? Dr. Irene, would you mind unmuting and reading it out? I just randomly picked you, Dr. Irene. I don't even know where you are coming from. Can you unmute? If you have a problem, I am sure Dr. Shubhra or Dr. Ruba Kumari are standing by to jump in and read it. Somebody please volunteer. I am almost in tears. Anybody, please unmute and read it out.
Shall I?
Yes, please.
Yeah. In India, the poor die in misery of neglect, and the middle class die in misery of ignorance, and the rich die in misery on ventilators. No one gets a pain-free and dignified death. So true.
Doctor, thank you. So it enabled me to have a drink of water. Relieving my misery, mitigating my suffering. This was written by Dr. Sankhamitra, a British oncologist. He lives in Australia now. He is unwell now, but till he had a health issue, he used to come several times to India. He had formed an organization called Eastern India Palliative Care. He used to do charity work in the northeast of India. And he felt this. He had studied medicine in India. Then he had gone to UK. And he came back to give back to the country. And he said this. Can I have a vote here? Hey, how many people? 28 people here. So apart from the palliative care thing, there must be at least 24 people, oncologists here. How many of you are able to think about your own death? I don't know. I am taking a guess. Most of you I see on the screen are young. It's easy for me to talk about my death. It may not be easy for you. Those who are able to think about it, I won't force the others. I wish you immortality. But those who are able to think about your own death, please tell me, answer this question. Where would you like your end of life to be in?
So most of them are answering is at home.
So we'll take the count, Sangeet, or Manu, at the end.
Okay.
More people.
Only one person, one doctor mentioned depends on the situation, maybe. Dr. Vasundhara.
Right. Oh, so many want to be at home. Hey, look, that's a big responsibility for us, because we have to make sure they will get enough support at home. It's great to be romantic and say we want to die in my own bed. That's what most people like. But I personally will go with Dr. Vasundhara because I'm scared. I'm scared that if I get breathless in the middle of the night, I can't take in air, what's likely to happen? My family will panic, and rush me to the nearest hospital. And before they know what's happening, I'll be on a ventilator. I would like to be in my home, in my own bed, in my own side of the bed, like you, where I feel connected. If you, Dr. Sai Kumar or Dr. Rama, can give me some support to be there at home, can I have a 24-hour helpline, at least on call? So I'll agree. So how many people, I mean, nobody opted for the ICU, right? Did anybody opt for the ICU?
No,
I
sir.
didn't ask.
No, sir.
But Dr. Vasundhara was the only one who did not say home, right?
No, yeah, she said depends.
Depends.
Sir, I think that pre-decided, sir. It's totally based on the circumstances and what
Yes.
illness you have, what is the state and all.
So Dr. Vasundhara and I would keep it open, because if I cannot get enough support at home, I would want it in the hospital, but not in the ICU. For the last 1 hour and a half in my home here, a family, including the patient's brother-in-law, from a physician from Australia, they're sitting and agonizing over their 96-year-old mother, who is in a hospital, mercifully not in an ICU because the family gave it as a condition, but in a hospital. Nobody chose ICU. Strange. But almost all our patients, they seem to end up there, right? In your own hospital? I hope not. But the truth is the majority end up at home, end up in the ICU. Friends, I have here data from two sources. The first on the panel on your left, we have data published 2019 in JAMA. This was from multiple hospitals in European Union countries, which showed that almost 89.6% of patients in the ICU with advanced illness, when the treating physicians considered that return to reasonable quality of life was not likely, either with the patient's advanced medical directive or with the concurrence of the family, withdrew the life support systems and instead provided palliative care. Compare that with what happens in India. Dr. Rajagopal Mani is perhaps the person who published this, is perhaps the most well-known critical care physician and past president of Indian Society of Critical Care Medicine in the country. And he published it even more recently, showing that almost 70% of all patients, even when treatment was considered futile, died on the life support systems, their deaths being stretched out to prolong the suffering. And the other 30% mostly died without receiving palliative care. They were asked, the families were asked to sign LAMA, leave against medical advice, and take the person home to receive no support. See the contrast? We are going to change it. Oh, when I say you, we, I mean mainly you. And thankfully, you all have done it already, taken several steps. Most of you must be working in hospitals which are members of National Cancer Grid, the phenomenal organization in our country. We are blessed to have National Cancer Grid. We are blessed to have Dr. Pramesh leading it. And in their 10 things that they give in this article, which is available for free download, I have given the link there. Sangeet can send you all this presentation. I would, if anybody has not seen it, I would request you to see it. It gives 10 things that are better not done. 10 things that should not be done. And one of them is, do not treat patients with advanced metastatic cancer in the ICU unless there is an acutely reversible event. I can accept ICU treatment in somebody in whom you are giving chemotherapy and there is a downturn and he has gone into hyponatremia and several other problems, or drop in white cell count, and you want to restore the person back, possibly to eventual recovery, then it's okay. But a clearly dying person going into the ICU is a rather horrible thing. Please note this, I am making this plea. I have written my advanced medical directive. I have kept it in my file with the medical records. Please don't do this to me. I want to be with my family. You will have detailed discussion on this. There are several barriers. Many of you must be thinking, but families command forces. True, that happens. The society also has come to accept ICU death as a norm. That's part of the problem. And some of you may say, law doesn't permit it. I would disagree. There are legal barriers, but a Supreme Court judgment in 2023 has made clear recommendations for validating my advanced medical directive and for withdrawing artificial life support. Only thing is there is a process to follow. This also will be dealt with in detail. I am sure you will have a session on end-of-life care. But we talked about some problems. There are some more to be talked about. We treated this woman's pain successfully. She would get excellent pain relief, but the problem was that she would not adherent to the medicine regime. She was not committed to the treatment schedule. Whatever we say, next time we go on home visit, we will find that she's taking her morphine only 3 times a day, and she should be taking it 4 hourly. And she was annoyed. When that happens, there's no question keeping on saying, why are you not taking the medicines? I told you 7 times, take it every 4 hourly. I know that doesn't work. Instead, I would say, you're not taking them. There must be a good reason why you don't. Tell me. I won't tell you the whole story now, but we need to realize that her problem, we are trying to treat her serious health-related suffering. It's not only physical, it's emotional, social, and spiritual. Is it the duty of an oncologist to treat spiritual suffering? I know you won't have the time. But Dr. Mohammed Shafi, Dr. Manjusha, you have a duty to mitigate my suffering. You will not be able to do this all. But you certainly can have a few medical social workers giving psychosocial support. With a salary for one doctor, how many medical social workers can the hospital appoint? Many. And they can do precious work if one's empowered. So this is palliative care for me today. I know this is not the WHO's definition. Unfortunately, WHO definition is 22 years old. Since the publication of this Lancet Commission, hey, can I make a personal request to you? I've given the link here. It's an open access article. Sangeet will send the presentation to you so that you will have the link. Please read the executive summary of this article. I'm sorry, executive summary itself is about 5 pages. but please read that. Uh, and since the publication of this article, when the commission, Lancet Commission on Access to Palliative Care, brought out this document and brought out the concept of serious health-related suffering, even found a way to measure it at the national level. Actually, Dr. Richard Horton, the editor-in-chief of the Lancet group of publications, came out with an editorial saying medicine can never be the same again, because the commission is pointing out your responsibility and mine to treat suffering. And the numbers are huge. I'm not only talking about cancer. Cancer is only one of the diseases that causes serious health-related suffering, but still, in our country, cancer is the largest group, accounting for about 30% of all serious health-related suffering. Globally, it is HIV. Cancer becomes second. But in our country, cancer comes first and HIV comes second. In Kerala, cancer comes first and dementia comes second. This is the WHO definition. And if you can, Manu, we should declare an award for anybody who can memorize this and, repeat it. Oh my God, it's about how long? How many kilometers long? So let us concentrate on a few points. It's about quality of life. Earlier we said it's mitigating serious health-related suffering and improving quality of life. Let us add that. Of patients and their families. Families also. Doctor, I am ill, you are treating me, but this is not only my life, this is also my wife's life. This is not also my children's life. They are suffering. My grandchildren are suffering. And please have that social worker around. You may not have the time. In our country, I know how busy you are. Dr. Chris Booth once wrote an article. I don't know if you have seen this. I can't remember it offhand, but in his one-pager article, he said, I think it was in Lancet Oncology. One of the things he mentions after his first trip of 3 months to India, he said, an oncologist sees 15 times as many patients in India on an average compared to his country. You can imagine how you are. But I hope at least you will be able to see the suffering in my wife's eyes. And maybe the social worker will be there to answer her questions. And if she finds my wife is in clinical depression, at least direct her to the right treatment. So if we are accepting the WHO definition of life-threatening illness, I will remind you that life is more than just a beating heart. Life is something that includes some enjoyment. And Christopher Booth again has written, he has formed a movement in which he talks about this. If you have this new chemotherapeutic agent, which can extend the life by an average of 4 months, it is not just the length of life that you should think about. How much of those 4 months will be spent in hospitals? What will be the quality of life? That is another question to be asked. So, in illnesses that threaten life in terms of quantity or quality, we want to prevent and relieve suffering. Suffering in terms of pain and other physical problems, psychological, social, and spiritual. But as I told you, this is 22 years long, old. This question of life-threatening illness is causing a problem. Unless my suffering clearly seems to be terminal, many people may not give me palliative care. that I hope as future leaders of palliative, onco-palliative care in India, I hope you will remember this and ask our colleagues to remember that life is more than a beating heart. Shall we take a poll? Sangeet I did not give this to Sangeet to do a virtual poll, but you can give your answer A, B, C, or D on the chat box.
Most of the answers come as C, sir. C. That is at the time of diagnosis.
I think that's an excellent answer because this is what WHO says. WHO says it should start at the time of diagnosis along with disease-specific treatment. Okay, thank you. But I have a problem. If I am falling in that 10% cancer group someday, and I come to you, sometimes you can take quite some time to arrive at a diagnosis, right? Most of the time in a week or two, sometimes as long as a month. So okay, WHO says this. Who am I to argue with WHO? But a personal request to you, Dr. Richard, Dr. Sherin Matthew, Dr. Rama, Dr. Manasi, everybody, personal request to you is even before that, if you can give me some comfort, because often pain is the presenting symptom, and sometimes it can get agonizing in a day or two. I hope you will consider treating my suffering, even if there is a delay in arriving at a diagnosis. But then I know I am not WHO, of course. So I will have to leave it to your discretion. This is what WHO said in 2002. Applicable early in the course of illness in conjunction with other therapies that are intended to prolong life, such as chemotherapy or radiation therapy, and includes those investigations to treat distressing clinical complications early in the course of illness. And I am personally requesting, please do that when my suffering starts. And particularly important, I don't know, many patients actually have their possibilities hidden by them till they are brought to a cancer center. The first inclination that they may have cancer is when they are, say, regional cancer center. That's a time of great agony. I hope somebody will be there to answer my questions. Our NCG, the NCG that we are all very proud of, has this also among the 10 recommendations. Do not delay or avoid palliative care for a patient with metastatic cancer because they are pursuing disease-directed treatment. What the WHO said in different words, very important. And National Cancer Grid says this also. This is another one of the 10. Shall I leave you to read it? But I know it is not only up to you. Sometimes the patient herself or himself may say, I am a fighter, doctor. But let us continue. Even if my chance is only 5%, I want to do this. Not very often, but sometimes, yes. But even more so family, and particularly the case of children, oh my God. They dog your footsteps and come and say, doctor, please, 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 don't give up on my son. I know he's a fighter. There are problems. That means just saying, no, chemotherapy is not useful, may not be enough. That means somebody, if you don't have time, somebody in the team will have to sit down to them, listen to their story, and help me. Because when my time comes, though they have now agreed, my family has agreed, at that time they will say, no, please try, doctor. I just wanted to, I'm not going to go to any symptoms, but you are confronted with this all the time. Your patient, you are planning on palliative care, comes to your cancer hospital in the middle of the night with intense breathlessness. So I will tell you what I do, but then I am in a palliative care center. They don't usually come to us expecting to be on an ICU. But I would, when my time comes, I don't want you to be in an ICU. I'm not talking about a fracture rib where if you treat me in the ICU, you will save my life in a week or some other disease like that. I'm talking about advanced incurable cancer. I want my family by my side. Doctors, I know you will not have a lot of time. You will be busy. Dr. Fasmia, Dr. Duba, my personal request to you is, at that point of time, you will have to rush away to your OP back. You are seeing me only for a minute. But during that 1 minute, if possible, sit down beside me. Look into my eyes and say, I see you are suffering. Just that one sentence will give me relief because, oh, thank God, I have a human being treating me, not a robot. We will do the best for you. That itself will be a great thing. Reassuring is not saying everything is going to be okay, don't worry. Don't worry doesn't stop people from worrying. Who stops worrying because somebody told you not to worry? You are not deliberately worrying. Okay, you are not taking a decision. I am going to worry for the next 15 minutes. It comes uninvited. Instead, say what you see and assure to do what you can. Never promise the impossible. Oxygen is not a must for every dying person. Oxygen is a medicine to be given at the appropriate dose, at the appropriate indication. What I'll tell the family is, we will put the oxygen on. If, that equilibration between your inspired oxygen and arterial blood takes only an average of 3 to 5 minutes, at the most 7 minutes. So in 10 minutes, you will know whether the person gets relief. At that point of time, the pulse oximeter may be insignificant. Even if the oxygen saturation increases from 67 to 73, it's not going to help me when I am dying. If it doesn't relieve me, I'll be uncomfortable. I'll be trying to take this out. You have seen it all the time. The patient takes it out. So, Dr. Giri, what does the nurse do? The nurse puts a plaster like this.
Sir.
And as soon as her back is turned, I pull it out anyway. After some time, the nurse and Dr. Giri pretend that they don't see it. And the mask is like this,
Yes, sir.
enriching the atmosphere.
Yes, sir. It's socially seen.
See, if you are not feeling better, if there is enough oxygen, enough ventilation happening in there, If the transfer between alveolus and capillary happens, then the saturation will improve. But if a major bronchus is blocked, it cannot happen. Or if the alveolar capillary membrane is thickened due to illness, something happens, then it will not. And if it does not help me, it makes me uncomfortable. It's like being in a claustrophobia. Everybody must have told you, when there's a very breathless person, open the windows, let fresh air in. And mask is just the extreme opposite. I'll give corticosteroids to reduce the peritumor edema. I know it will take a few hours to optimally act, but that may cause significant relief. And strangely, contrary to popular belief, low-dose morphine helps. Again, this will be discussed more in greater detail during the sessions on symptom control. I just wanted to give you an example of how symptom control becomes different in the context of advanced incurable cancer. But here we have a problem, doctors. I am saying that everybody should get palliative care right from the beginning. How many palliative care physicians would you have? The majority would you not have a palliative care physician in your hospital. And when you start practicing palliative care, you may be the only one doing it along with your oncology practice. How much burden can you take on? The answer is to follow the 10-year-old resolution of World Health Assembly, which has been mostly accepted by all high-income countries. First world has accepted this. Every medical student learns principles of palliative care, so that every one of you can integrate palliative care into your practice. Your nurse also can. And then your patients will get good palliative care. But there will be a percentage of patients in whom you will need a more experienced person. For example, some people, the palliative care physician comes and says, hey, this we can do. We can give him a stellate ganglion neurolysis, and that will relieve this. There may be procedures. There may be more expert combinations of medicines. So, if I am to get relief tomorrow, you should have palliative care both in the primary, secondary, and tertiary level. Paradoxically, in Kerala, primary level palliative care is more available than in tertiary hospitals. And this should be from the beginning of the suffering to the end. So the bulk will be the palliative care that you give along with your oncology practice, the middle part of this triangle. And only a minority will have to go to Manu's palliative oncology department. This may sound too idealistic, but I can tell you that this is already happening. You are here, that's the example. India has a national program for palliative care. The law governing opioids have been amended so that it is it's easier to access morphine, methadone, and fentanyl. The national policy of 2019 includes palliative care at the primary level. And we are going to be old-fashioned. The medical students from 2019 have all this in their curriculum. I know there will be an implementation gap. Our organization and others are working on filling that gap. But tomorrow, we are going to have a generation of young doctors who can include palliative care as part of their routine medical practice. The undergraduate MBBS curriculum now has 20 modules under 12 themes related to palliative care. All to be starting from the foundation course in the beginning of the course up to the internship. So this is a tremendous advance which makes this integration quite a possibility. And for anybody wishing, your friends who cannot attend this course, because this time they will not be free. They are still working in this 7 p.m. slot. We do have a massive open online course available on our website. Just go for training, that page. And we have materials for undergraduate education, so that in the medical colleges that you work in, you can use these resources to teach your medical students. I'll stop there. And I see that we have just... Hey, Sangeet, you have a case presentation for the day?
Yes, sir. As today is the introduction session, we have a model case presentation which is presented by Dr. Manu John.
So before Dr. Manu starts his case presentation, Manu, can we take a few questions?
Yes, sir. Yes, sir. Those who are having doubts can put in the chat box or unmute and ask directly. Dr. Vasundhara is asking, are there any books or materials available?
Sangeet?
Yes, sir.
Our Indian Primer of Palliative Care, please find the link and provide it to the group later.
Sure, sir.
Dr. Vasundhara and others, we have a book, Indian Primer of Palliative Care, which is the online version is available for free. You can download it from our website, Indian Primer of Palliative Care. If you want a print copy, you will have to pay, I think, I don't remember how much it costs, something like 250 rupees or something. So we can also buy a print copy. It was created by a group of working group, including oncologists, but primarily worked on by Dr. Nandini Vallat, who is now in St. John's, and many others. So that book is available for free download. Okay, thank you. Thank you, Sangeet. Sangeet has written in the chat box that it will be made available to you.
So,
Of course,
if you have any...
Dr. Vasundhara, there are many other books, but this is inexpensive and free for download. So that's why we offered it. Sorry, who was speaking? Was it Manu? Or?
No, sir. Sangeet, I was just informing the participants if they have any questions or
Okay. I have a feeling that the group has not had the ice broken yet. They're still being a bit formal. Dr. Shafi, thank you for smiling. Majority of people are much too serious. Hey, please don't be so serious if I come to you for treatment, okay? Please be ready to smile. Give me a smile.
So, Dr. Debashish Das has written buprenorphine patch they are using in West Bengal.
Dr. Debashish, buprenorphine patch is available, yes. And it is not under the same control as step 3 opioids. It's a medicine that comes somewhere between step 2 and step 3. So the problem is buprenorphine, that for patients who require high doses, it will not be enough. For those who require, say, doses of morphine that's about 20 milligrams 4 hourly, buprenorphine will give an inadequate pain relief. Secondly, the fentanyl patch is for 3 days, this for 7 days. Great, isn't it? But the problem is, no. Dr. Geeti is saying no. Dr. Geeti, why not? Please
Maybe
unmute.
titration may be difficult, sir.
Titration is more difficult. Titration is more difficult, and that's why titration is more difficult. Secondly, it has a ceiling effect. The medical, that is, you cannot increase the dose beyond a certain limit. Fentanyl, you can add a second patch and a third patch as required. Okay, thank you. Thank you very much. Manu, I'll stay on for some more time, but somewhere in between I have to go. Please bear with me.
Yes, sir. Thank you, sir. So, Sagid, can we go ahead with the presentation now then?
Yes,
So,
sure.
can we proceed? Yes. So, this is a model presentation we'll be doing today. And in the coming weeks, I think there'll be presentation from the participants.
We will share a template with the group to share your case presentation. Kindly look onto it. Thank you. So is the screen visible, sir?
Yes,
It's
it
visible,
is
visible.
well visible. Thank you.
Thank you. Thank you.
Yeah, so we'll start with the presentation. It's a case of a 45-year-old male who has a diagnosis of squamous cell carcinoma of gingival-buccal complex on the left side, now recurrence. So he has a presenting complaint of pain in the left lower jaw since 3 weeks. And he has history of squamous cell carcinoma left buccal mucosa in 2022 and had 12 cycles of radiation, 12 fractions of radiation and 3 cycles of chemotherapy with cisplatin. He had an ulcer at the same site and discharged from the same site 3 months back, along with foul smelling ulcer. And currently he's under chemotherapy and he has somehow planned to have surgery after chemotherapy. He is currently on tramadol tablet 50 milligram 3 times a day and paracetamol 500 milligram SOS for pain. But still having continuous pain past 3 weeks. It's not reducing with the above mentioned analgesics. So we did a pain assessment. We have a mnemonic for pain assessment. That is OPQRST to remember. So that is the site of pain first, the left lower jaw, and onset of pain happened 3 weeks ago. The provocating factors are chewing or swallowing and any movement, any sort of movements. Whereas palliative factors, that is anything which comforts the pain, it is not related with analgesics. So there are no palliative factors now. And quality of pain, how it is, it's continuous dull aching pain with sharp shooting pain to the ear and forehead. And it's radiating to left ear and forehead. It's very severe. And temporal factors like it is more during the night time. Hence, sleep is disturbed. And numerical rating scale of pain, it is 7 out of 10 is a score. And on local examination, there is the patient is conscious oriented, moderately built and nourished, no pallor-icterus, cyanosis or clubbing or generalized edema. But he has a lymph nodes are there, the submental and submandibular areas. Lymphedema is present in the submental and submandibular regions. Vital signs it's all normal. Systemic examination was normal. And local examination, there is an ulcer proliferative lesion, approximately 2 into 2.5 centimeters along the buccal vestibule and gingiva of mandible. Left side, the left premolar region, and along the buccal vestibule of the residual alveolar ridge of first molar and over to the residual alveolar ridge. On palpation, lesion was tender, no bleeding at present. Xerostomy is there, caries is there, and pressure salts nil. Routine investigations were done, and like blood workup, CBC platelet were normal, electrolytes were normal, renal function test and LFT was within the normal limits. CT plane and contrast that was taken May that showed enhancing lesion involving the left side lower GB sulcus and with an erosion of left mandibular alveolus and left submental and submandibular metastatic lymph nodes. And medications were slightly revised Added moxiclav, antibiotic moxiclav, 625 milligram, 3 times a day for 5 days. Pantoprazole was added, 40 milligram once daily. The morphine was initiated 5 milligram 4th hourly, plus 5 milligram SOS and 10 milligram at the bedtime. And the paracetamol dose was hiked from the SOS dose to 500 milligram 6th hourly and SOS. And dexamethasone was added in the tapering dose pattern, started with the 8 milligram and then 4 milligram and the 2 milligram. And the bisacodyl was added 5 milligram, 2 tablets at bedtime. And metoclopramide was added 10 milligram 3 times a day for 3 days, and then if required may be taken as OS. And amitriptyline was added 10 milligram at the bedtime for 1 week, and the plan was to increase after assessment during follow-up. And patient was advised to have good oral hygiene and cleaning and dressing to be done twice daily. These medications, of course, as you know, pain medicines that was modified from the tramadol to morphine 5 milligram Q4 hourly, and paracetamol SOS we changed from the SOS dose to 6 hourly dose. And other medicines, antibiotic, the moxiclav, other dexamethasone, amitril. These are adjuvants. Like you may be coming in the coming sessions. We'll be dealing with this in detail. So they're adjuvants, not exactly analgesics, but they're adjuvants needed along with the analgesics to give better patient comfort. And regarding this bisacodyl, look, along with morphine, usually we give bisacodyl because we know that one of the most common side effects of morphine is constipation. And some patients will be having vomiting, nausea sensations. So to cover that, we give metoclopramide in the initial 3 days, and then to give SOS. Next slide. So that was as a physical part and the medicines which we covered. Coming to the psychosocial aspects, he's a businessman and he's a sole breadwinner of the family. His wife is a homemaker. They have 3 children, all school going. He's a very religious person and belonging to the middle socioeconomic status. He's concerned about the disease recurrence, and he's anxious about the future and regarding the present disease, whether he'll have cure or not. And sometimes he's showing anger towards his family members. Of course, he has having pain and other distressing symptoms. And he was concerned about disturbing sleep of wife during night as he's in pain. And this patient, where the main concerns are pain, main aspect, and concern about family members, whether they'll be affected or not, including their sleep and the breadwinner status in the family. And he's also concerned about recurrence of the disease and further treatment options available or not. So in this summary, he's a 42-year-old man with squamous cell carcinoma, GB sulcus. He's having persistent pain, lower jaw, past 3 weeks. Currently, he's managed by oral antibiotics, oral morphine, and was added to his pain regimen. Next slide. We are having a few discussion points in this regarding this case. So, how to assess total pain in this patient? Of course, we know that it's a total pain concept. It's not just physical pain. There is a total pain concept in palliative care. Sir, Raj sir, are you here? I think Rajagopal
sir has left.
Okay. Any comments regarding how to assess total pain in this, or what are your takes? What are your points regarding the total pain concept of this patient? Can anyone unmute and say or put something in the chat box?
Participants, please feel free to express your views and thoughts on this answer. And if you can unmute, that is better, or else you can put your opinions in the chat box.
Yeah, let it be anything. Let the opinion be anything. Like we're just starting the sessions, just starting the course, you can answer anything. How to assess the total pain in this patient?
Right. So the total pain is not only the physical pain concern. It includes the psychological, it includes the spiritual, as well as the social pain also. So if we address only the physical pain, the patient is not going to be relieved of the pain. We have to take together all these aspects and treat them comprehensively.
Exactly, Doctor. Thank you. Thank you so much for the answer, and thank you others for the chat responses. As Doctor mentioned, right, this is the physical part which we see, that is just the tip of the iceberg. That is just the tip of the iceberg. The rest all lies underneath. So if we just tackle the physical aspect, the patient's pain may not go off, and we'll be like struggling what to do, what next analgesic to be given. Still, the other issues will be going unaddressed. Okay, answers are all supporting the total pain concept. Last answer also social, spiritual, psychological, yeah, everything, mental agony, social aspects, and the financial aspect also. That is also an aspect, especially regarding our, as we know, treatment expense. And also the family also will be affected. Family member may not be able to go for the job and such aspects. So it's a total pain concept. So we may not be able to solve everything, but at least we can start addressing the other issues. So that there may be solutions. Sometimes we come across people who are willing to donate money, willing to help someone. So the financial aspect, to some extent, maybe we can do something regarding that. So how to address the total pain in this patient? Of course, this may be the answer. Regarding whatever issues the patient will be having, we need to address it separately. If we have a psycho-oncologist in our center, if we have a psychologist in our cancer center, it's always better to involve them initially itself, so that the patient will be having a better time. They'll be able to cope up with the initial diagnosis part and the initial shock regarding the disease and the treatment part. Okay, and spiritual persons, if any, in your hospital, they can involve them also. So how can we better manage pain in this patient? Is there any suggestion? How can we better manage pain? Okay, initially we started with tramadol and paracetamol. We had additions later on, as you saw in the slide. So any suggestions, further suggestions? Just from your side, we can just listen to you.
So in head neck cancers, the another issue is the local control. Sometimes you have added amoxiclav, that's a very good decision, as well as the local cleansing. Some sort of oral care needs to be added along with the gargle or in the form of just rinsing the area.
Yes, definitely. And if we suspect any anaerobic infection, we can add some metronidazole also.
Right.
Yeah, since it does not have any bleeding and all, we can add that. And of course, we are going ahead with the chemotherapy or other treatment. That also will be helpful. So that almost completes the discussion points. And is there anything which, is there any questions regarding if not, we can take one or two questions if necessary, or else we can wind up the session for today.
So for physical pain, we have scales. We have pain rating scales, numerical rating scales.
Yes, ma'am.
So I would like to know whether there are any scales for the psychosocial assessment also of this patient.
Yes, ma'am. There are distress scales available with the, especially the psychologist. That's what, like, if we have the distress scales, and if you're able to involve the psychologist also, that would be a great help. They can assess the distress and may suggest adding any anti-anxiety medicines or antidepressants if needed, because they also will be helpful to reduce the pain also and to get a good sleep also.
So the distress scale is the one that is commonly used.
Yes. In the coming sessions, the rest of the sessions we'll be dealing with again the non-opioid pain management. The pain assessment scales will be coming in the coming sessions, and opioids and the other sessions are like in the pipeline. Yeah, it's 8:15. If there are no more questions, can we wind up the session?
Yeah.
Geeti, yeah, good evening.
Yeah, thank you.
Okay, Rajagopal has given us more insight as the introduction of sessions today. I hope you have all listened very well. Thank you, sir, for that. And thank you, Dr. Manujan, for facilitating the entire sessions and solving the doubts of the participants. Thank you all the participants for keeping your video on and listening to the sessions, today's sessions. Thank you. Let's see in the next sessions. Thank you. Bye.
Thank you.
Thank you. Bye. Good night.
Bye.
Thank
Good
you.
night.